On the second part of this presentation, we will address the possibilities of treating the sleeve gastrectomy leaks by means of endoluminal approach. And you're going to note during the presentation that all the methods that we will show you, they have an intention of having like a surgical thinking. It meaning that those methods, they aim to release the pressure, the endoluminal pressure of the sleeve gastrectomy, and sometimes occluding or not the hole. And the key for success and how efficiently we can release this pressure, and we're gonna let the body heal itself, the abdomen heals itself once the pressure is correct. And all the methods will touch more or less in those points of hyperpressure system. So what are the options we can use to treat sleeve leaks by endoluminal approach? Is that what we will intend to show you right now? So if we go to the literature and we got the old literature up to 2010, 2011, we're going to see here that most of the literature address of endoscopic treatment for sleeve leaks with stents, and with a success rate of 74% using in all periods of the leak related when it happens after surgery. So there is a classification that is broadly used nowadays, that it comes from this International Sleeve Gastrectomy Expert Panel consensus and a statement, and this that we had take part of this, and it divides the leaks in terms of timeline in acute up to 7 days early, from 7 to 45 days later, 1.5 months, that's 45 days up to 3 months, and chronic when it comes referred after 3 months. So based on this classification, our group developed an approach that had been using for quite long right now with very good results. That is, if it is an acute leak, we stent it with bariatric stenting. It means that the new bariatric stents that is very different from the usual esophageal stents. Those stents, they are longer and larger, and they are able to detour the food flow from the esophagus into the duodenum or into the antrum. Just to give an idea how different it is, the esophageal stents that we use off-label to treat leaks in bariatric surgery, the longer is 155 millimeters, and the wider is 23 millimeters. These new ones can go up to 30 centimeters and wider as 30 millimeters. And it is a game change, at least from our perspective in that field. If the leak is early, and as more you go on the direction to later leak, you should expect that the stent will solve the majority of the cases, but there will be some cases that some additional procedures should be done, like pneumatic dilation. When it comes to the later leaks and chronic leaks, the approach for us is to perform a septotomy that we will describe for you, and pneumatic dilation, and we can exchange the order of pneumatic dilation, then septotomy, or septotomy, then pneumatic dilation. It is done in a stepwise approach in sessions each 7 to 10 days up to the heal. In general, 2 or 3 sessions there are enough to close those later and chronic leaks. So getting back to acute and early, where we prefer to use the stents, bariatric stents, I'm going to show you a cartoon about how the leak happens. You see there's a narrowing or twist between the body and the antrum. It impacts on the hyperpressure system on the fundus in a weak spot that is angle up to the point that it will leaks. So in those acute cases and early, the approach is to implant a stent. And as you're gonna see right now, these stents have to fulfill two main goals. First is to release the pressure, and second is to occlude the hole. And to make it to fulfill these two topics, you're gonna see here is a post-pyloric distal part, and the proximal part goes into the esophagus, and it will detour the food flow from the esophagus into the duodenum, allowing the abdomen to heal itself over this mold that is impermeable. So after no more than 2 months, in general 4 to 6 weeks, we remove the stents. Those stents, they are self-expandable metallic stents, fully covered, and that's the trend for those bariatric stents. To note that in US, the FDA did not approve directly the use of stents to treat leaks, so they're using off-label. And the only stents they have in US to be used is the esophageal one that I described before, and that gives a challenge for those cases where sometimes the stent is not long enough to occlude the hole and release the pressure, meaning to release the pressure, you are obliged to pass through the incisura angularis, otherwise you're going to keep the pressure high and the leak not going to heal. And an option that quite some services using in US is to put 2 stents on proximal and distal, or to put a stent that are going to be fair, and then they're going to suture by means of endoscopic suturing the proximal part on the esophagus. When it comes to later and chronic leak, we will describe the approach our group had created, that is the septotomy. And it comes in a way that if you have ever witnessed an endoscopy on a sleeve leak, you're gonna remember and recall that the lumen is between 3 and 5 o'clock in the screen of the scope, and between 9 and 11 o'clock is the leak site or the abscess. And in between them, that's always, I can tell you, always pretty much, a septum dividing those. In general also, the leak site is higher than the lumen. So it directs the flow of the food and saliva or wherever into the cavity outside instead of going to the lumen. So our intention, as I'm going to show you in the cartoon, is to divide the septum up to the base of the abscess cavity or the cavity itself in a way that we're going to reroute the flow. Au pair, we should perform aggressive pneumatic dilation, in general balloons of 30 millimeter up to 20 psi, and it will help by breaking the fibers to correct the axis deviation and or the narrowing on the incisura angularis. And this is very important because if you correct this axis, if you correct this narrowing, you're going to release the pressure. So they come together, septotomy and pneumatic dilation. We're going to show you right now. So you're going to see here the scope, and by means of argon plasma, as you can see here, or by an electric knife, you can cut it, and you should do pneumatic dilation also. By doing that, and it's also, it for sure is a cartoon, we reroute the flow, and we're gonna see that the body gonna heal itself in a way like laparostomy. When you try to close, you approximate the edges. This is gonna be pretty much the same, and it will allow the body to heal itself. This technique it is being published in quite some papers. As you can see, this one here, by the pictures, you can see how dramatic the cases that we have treating on that. So you can see here, even in Sage's manual, we have a chapter about describing the gastric septotomy and also creating the term internal drainage, and that we're gonna tell you after that other methods had been using internal drainage also. And this is a very recent one that was published in a business surgery. And this, as we can tell, as in a matter of experience with this method, we have already more than 100 patients with all data collected, and this is the matters of my PhD thesis that is running right now. Another way to deal with those chronic leaks is to promote internal drainage by means of double or single pigtail drains. This approach has been recently described, and we can quote now there is more than around 5 or 6 articles, small series, case reports. What is interesting about this technique is that the endoscopists in general, they are quite used to implant those pigtails in ERCP or papillotomies, as you can see here. So if you go to the pictures A, B, and C, you're going to see how it goes. In general, 2 of those pigtails, they are delivered, meaning with the one end into the abscess cavity and one end into the lumen. So this will match the pressure and will balance the pressure, making them to heal. One characteristics of this technique, you can see here from the left to the right, the heating on the first 2 pictures, is that it takes more time than septotomy and than stents. The reports tell about us about 2 or 3 months, even 6 months to heal. But the patient can be at home and eating. Another thing to consider in this technique is that we should address the axis deviation with pneumatic dilation or with a stent. Otherwise, you're going to see from the picture from your left into the picture of your right. So the leak is healed, but you can clearly see here that it's twisted. So the hyperpressure is still there, and there is a possibility that, it was described with this technique, that the leak can reopen months later. And how about endoscopic suturing? So this one is really appealing. Why not close the hole that means the leak? What I can tell you is that suture alone should not work. And why I'm saying that is that if the laparoscopic suture is not working to close this heel, why endoluminally it will? So it's very hard to get that. That said, one very good use of suture is when you use a stent and you can fix the stent by means of a suture proximally. You can see your left to your right, and it will promote the stent to be stable, and it will to define the heel. Direct closure, as we can see here in the inferior picture from your left to your right, is being attempted, and there's some reports of success. But in general, what we see from those reports is that they come from very bold and large sleeves, and most of those sleeves will heal even by themselves. So we have to create a way to do a trial or some trials to balance that. On the picture, on the upper part on your right, you're gonna see here some sutures applied to a stent in order to stabilize it. And also another way to treat that is using the over the scope clip, also called the bear claw clip. So you can see here there's some literature about this, and when we go for more cases, the success rate is between 60 and 70% rate. Our success rate with the previous methods described to you is around 90%. And we will finish this presentation saying to you that endoscopic approach can help even in the worst case scenario. And I'm about to show you one publication of us, just kind of old, from 2011, and that endoscopic approach can treat even the most severe of those leaks, such as the gastrobronchial ones. And you can see by yourself on the pictures that those cases treated, they were very dramatic cases, as shown on the screen right now. So from this article, and if you go to the right part of the chart, you're going to see the name angle of his in absolutely all of those. So getting back to the previous papers that showed to us that the majority of those leaks comes from the his angle, and is even more true when you're talking about gastrobronchial leaks. And also you can see here on the column on the extreme right, that is the healing time, and you can see here that takes a lot, in around 4 to 6 months. And you can see here that all of the numbers are there except for one, and it means that from those 15 patients we were able to treat with gastrobronchial fistulas, we were able to treat 14 out of 15. So thank you very much.